Welcome everyone to the AADMD Virtual Grand Rounds. We're very excited this year to start off a brand new year of wonderful presentations for you. We have a wonderful program tonight. We're going to be featuring autism and Down syndrome. AADMD is a very active component in many chapters across the United States and other countries. And our goal really is to improve advocacy, education, and access to care. And hopefully tonight you'll be brought forth some of that tonight and be inspired and tell other people. So without further ado, again, I'm Alan Wong, the president of AADMD, very proud to be that, and more proud to have these young professionals in front of us who are going to be presenting tonight. And with that, I'd like to invite Enamel Hypoplasia, who is going to be our VGR student facilitator. And on to you, Enamel. Thank you.
All right, thank you, Dr. Wong. Welcome everyone to Virtual Grand Rounds. So my name is Aadmt Ulcers. I am a third-year medical student at the University of Louisville School of Medicine in Louisville, Kentucky. I am this year's American Academy of Developmental Medicine and Dentistry's Virtual Grand Rounds coordinator, but I'll be filling in for our facilitator, Cindy Lee, who will be presenting tonight. For those of you who are new, Virtual Grand Rounds is a webinar-based presentation model that creates a space for mentorship, exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the Grand Round session is to expand and strengthen the IDD healthcare workforce across the spectrum of experience levels. Thank you so much for joining us tonight. If you have any questions throughout the presentation, you may write your questions in the Q&A box on the sidebar, and we will go over as many questions as we can at the end of our presentations. Please make sure to put the questions in the Q&A box and not the chat box. If we do not get to your question at the end, we will post the question and the answer on our website afterwards. So now I would like to introduce our webinar for tonight. This webinar will feature case presentations on autism spectrum disorder and Down syndrome that highlight the role of preventative oral health care, desensitization, and interdisciplinary communication when treating individuals with IDD. Presenters include current students, residents, and resident alumni from the University of Pacific, University of Pennsylvania, University of Washington, A.T. Still University of Missouri Dentistry and Oral Health, and the Marquette University School of Dentistry. The presentation will conclude with an update by Dr. Steve Perlman and Dr. Wong on current events and advocacy efforts. With that being said, I would like to introduce our first case presentation on autism spectrum disorder. All right.
Good evening, my name is Molly McGuire and I'm a current AGD resident at the University of the Pacific. I had the honor of working with Dr. Tyler Young, the past AGD resident, and dental students Rachel Thornton and Ardita Ajavazi. And tonight we'll be talking about the dental management of patients with autism spectrum disorder. So a brief background on autism spectrum disorder.
Autism spectrum disorder refers to a spectrum of developmental conditions that affects 1 of every 54 children in the US. Without a doubt, you will be treating someone with autism during the course of your career. Next slide, please. According to the DSM-5, in order to meet diagnostic criteria for ASD, a person must have deficits in social emotional reciprocity, nonverbal communicative behaviors, and developing, maintaining, and understanding relationships, as well as restricted, repetitive patterns of behavior, interests, or activities. These symptoms must be present in the early developmental period. Next slide, please.
It is important to keep in mind throughout today's presentation that once you've treated one person with autism, you've done just that, treated just one. We will highlight guidance strategies with high levels of evidence behind them, but by no means does that suggest that we will work with all patients with autism spectrum disorders. In other words, each patient will require individualized approach. Next slide, please. Many people on the spectrum struggle with hypersensitivities. That is to say that they might be sensitive to things such as bright lights or find certain sounds, smells, and tastes overwhelming. Here are some examples of sensory issues you might run into at the dental office. Next slide, please. In order to support these hypersensitivities and other behavioral concerns, I will now walk you through some recommended behavioral guidance techniques. The teach-based approach is a widely researched, evidence-based academic program based on the idea that individuals with autism spectrum disorders are visual learners. It promotes a structured environment with a focus on organization of time, space, and sequence of events in order to make activities clear and easier to perform. Teach emphasizes behavioral guidance techniques used with patients with intellectual developmental disorders that have been particularly successful with autism spectrum disorders. Those techniques include structured visual guide, tell, show, feel, do, social stories, in vivo modeling, and audio visual modeling. Next slide, please. Structured visual guides are described as a checklist method that strongly relies on work done at home with caregivers to prepare patients for their visits. It's important to utilize the visual guide before and during the appointment, even allowing patients to physically check off the item once it's completed. Tell, show, feel, do is a common model of telling patients what's going to happen by using simple verbal sentences, what he, she will feel or do, visual, olfactory, auditory, or tactile demonstrations, and finally, completing the procedure exactly how it was demonstrated. Next slide, please. Social stories are short, individualized social learning stories that help familiarize certain situations that patients with autism spectrum disorder may encounter. In vivo modeling is where patients are positioned in front of live models that display ideal behavior during a particular type of procedure. And lastly, audio visual modeling, which is similar to in vivo, but where ideal behaviors are filmed for particular types of procedures, for then which the patient can watch and review before the appointment. Studies found that using the teach-based program was effective in facilitating dental assessments by increasing compliance in children with autism spectrum disorder. Next slide, please. A bonus technique we wanted to discuss was deep pressure stimulation, which is found to be effective with autism spectrum disorder and is widely used among occupational therapists. It is simply the sensation produced from direct physical contact, such as holding, stroking, hugging, squeezing, and therapeutic pressure. It's important to note that this technique must be assessed on an individual basis, as not all patients with autism spectrum disorder positively respond to physical touch. Next slide, please.
Next, we'll discuss proven preventive strategies for children with ASD. Sealants is likely something a lot of you have heard of before. They keep plaque from getting trapped in the grooves of teeth and causing decay. Pros of sealants include they are effective, non-invasive, cheaper than fillings, and safe. Cons include they cannot be applied over decay, they can fall out over time, and they have both a grainy texture and an odd smell, with which, as Dita discussed before, can be particularly relevant for the ASD population. So one thing that might come in useful is practicing desensitization strategies with your patient. Allow them to bring the sealant material home. Allow them to taste it and to smell it. Next slide, please. Another strategy is fluoride varnish, which protects against dental cavities. Pros include the lack of need for isolation, prolonged therapeutic effect. It can be applied by both dental and non-dental health professionals, and children can eat and drink right after. Cons include the taste and sticky texture. Secondly, you are likely familiar with the fluoride controversy, which we will provide a resource at the end of today's PowerPoint, offering up evidence as to the safety and benefits of fluoride. Next slide, please. Finally, we present silver diamine fluoride, commonly referred to as SDF. It is effective in arresting caries or cavities and remineralizing tooth structure. Pros include its low cost, the fact that it's minimally invasive, and that it's easily performed. In fact, it does not require sophisticated techniques or instruments for application. You simply remove the cavity, isolate, and apply the material with a microbrush. Cons, however, are that it stains the cavity permanently black, which you can see in the pictures provided. You can conceal this with another dental material called glass ionomer if tolerated by the patient. Also, we'd like to mention that SDF has a funny taste. Next slide, please. We'll now move on to diet. Cariogenic foods are ones that cause cavities or decay and eat away at the tooth structure. An inclination to a cariogenic diet plays an important role in the development of cavities in children with ASD. To list some examples, patients with ASD tend to eat soft, sticky, sweetened foods, snack often, pouch their food in their cheeks, suffer from reduced salivary flow and quality due to medication. Oftentimes, they don't like water, which eliminates a daily source of fluoride and further contributes to the insufficient salivary flow. Rewarded for good behavior with cariogenic foods, struggle with trying new foods and eat the same thing, such as a certain pasta shape, and finally receive an insufficient amount of calcium and protein in their daily diet. Next slide, please. To counter the previously mentioned challenges, it is first recommended that you ask questions about the primary sensory concern. Is it color? Is it texture? Is it smell? With regard to dietary counseling, one can try a stepwise approach to trying new foods or fear foods, mix with favorite foods, offer up choices, or manage a specific sensory concern. On the last slide, we mentioned that food reward systems are common. So rather than rewarding with cookies, one might transition over time to anti-cariogenic foods or foods that don't cause cavities, rather protect against them, such as raisins, cheese, and milk. Next slide, please.
We will now like to poll the audience on which of the following is not a recommended management intervention for children with autism spectrum disorder. A, use of teleshow field dew as a behavioral technique. B, silver diamine fluoride application. C, stepwise approach of introducing new fear foods. Or D, low degree of caregiver collaboration. Okay, awesome. Thanks so much for everybody for participating. Next slide, please. Now, it's extremely important to emphasize the need for a smooth transition from pediatric to adult healthcare. This transition needs to involve all necessary interprofessional providers and be initiated while in early teen years. These providers might include unanticipated specialists such as social workers, occupational therapists, and board-certified behavioral analysis, to name a few. Next slide, please.
Now we will discuss the dental management of adult patients with autism spectrum disorder. Similarly to the care of pediatric patients with ASD, dental management of adult patients with ASD involves a patient-centered care approach. This involves collaboration with the patient's care team, including the patient's legal guardian, caretaker, primary care physician, nurses, occupational therapists, dietitians, and so on. Additionally, in order to deliver well-received care, we must understand the patient's preferences, habits, and level of oral hygiene compliance, and tailor their clinical care, home care recommendations, and our communication with their caretakers accordingly. Lastly, we also want to apply a preventative philosophy, such as caries management by risk assessment, or CAMBRA, to their dental care, and in doing so, we can address their dental needs at their source in hopes of preventing more invasive dental care. In accordance with a preventative over reactive philosophy of dental treatment, we can take advantage of multiple benefits of minimally invasive restorative techniques. This includes short appointments, avoiding necessity of injections, minimal tooth structure removal, and the use of various treatment modalities, including partial caries removal, glass ionomer, silver diamine fluoride, and even sandwich with GI itself. In using these techniques, we have the potential to prevent the need for root canal therapy and potential extensive surgery. In addition to minimally invasive surgical strategies, we can also utilize at-home topical preventive strategies. There are many options, including fluoridated toothpaste, xylitol sprays, gums and mints, remineralizing agents, antibacterial rinses, and something called MI paste, or amorphous calcium phosphate paste. There are many to choose from, and they strengthen the teeth and increase salivary flow to protect the teeth. The most important aspect is to recommend and prescribe products based on the patient's needs and the likelihood of the patient being compliant with the use of the supplement. Now I move to introducing more advanced behavioral guidance strategies. If behavioral guidance techniques that were presented earlier in this presentation are unsuccessful, oral sedation, medical immobilization, and general anesthesia are a few care management strategies that may be utilized. When considering oral sedation, consultation with the patient's primary care physician and pharmacist is extremely important to avoid drug interactions. Additionally, medical immobilization provides a physical approach to managing uncontrolled movements and requires specific consent from the legal guardian. And lastly, general anesthesia provides a mode of behavioral guidance that can be used when all other behavioral guidance oral sedation techniques are unsuccessful. On to hospital dentistry. General anesthesia administration is done safest in a hospital environment. When evaluating a case for hospital dentistry, it is important to consider the patient's medical history, the extent of dental treatment necessary, and of course, behavioral guidance. If it is found that hospital dentistry is the best option for the patient, obtaining consent is also extremely important and must be contained by the patient or legal guardian or another executive director of the regional care center or court order. While in the hospital setting, a wide array of treatment can be delivered, including anything from x-rays, examination, or oral surgery itself. Now we have another poll question, which we'd like to present to the audience. Which is not a recommended dental management technique in adult patients with autism spectrum disorder? A, patient-centered care. B, preventive approaches. C, maximally invasive dentistry. D, medical immobilization, or E, general anesthesia. Great, thank you for participating. And now we will have our case presentation.
Okay, thank you so much. Now everyone, let's tie some of these ideas together with a case and really bring things to life. Next slide. So this is a case that we saw in our clinic. Our story begins with a 15-year-old male who presented with his father for a hospital dentistry referral. The father stated that they had recently received an emergency evaluation, and the patient was diagnosed with pulpal necrosis and a chronic apical abscess. That is to say, a chronic and active infection that is draining into the oral cavity. The medical history was significant for autism spectrum disorder alone, and this can be rare for this population. It's important to note that some other common conditions associated include things such as epilepsy, ADHD, OCD, GI problems, and more. Now, likewise, this patient was also taking no medications and had no known drug allergies. Next slide. So let's talk about the dental history here. The patient's last routine dental visit was 5 years ago. That appointment was for a stainless steel crown, and the patient had a negative experience. Reportedly, the patient screamed and thrashed in the chair, and medical immobilization was required. Now, due to this traumatic experience, the patient has had a gap in routine preventative care. Now, the patient was recently seen by that same dentist for an emergency evaluation of the tooth in question and recommended for sedation in the hospital at our clinic. Next slide. Now, when receiving a referral, we always do our own evaluation. An active draining abscess or fistula was found adjacent to the lower right second premolar pictured here. Vitality testing confirms pulp necrosis with a chronic apical abscess, which is consistent with the previous dentist findings. When we have a tooth such as this, the only way to alleviate the infection is to clean the pulpal space, the center part of the tooth, the dark line, and clean the root of the tooth with a root canal therapy. The other option is to remove the source of infection by extracting the tooth. While extracting the tooth is often an easier approach with a faster time, there are negative effects of removing a tooth on such a young patient, and it would certainly affect his quality of life. So the ideal treatment is, of course, the root canal therapy. However, we need to make sure that we can safely perform this procedure with this individual. The previous dentist may not have believed that that could be accomplished in their office, which is likely why the referral was written for hospital evaluation at our clinic, and this patient found his way to my chair. Next slide. During this initial visit, we are looking at more than just the patient's teeth and their medical dental history. For any patient, as well as patients with ASD, it is critical to evaluate the individual. In order to let the patient's personality shine through, I began by setting the expectations for the appointment. I let them know that all we're doing today is taking pictures and talking. And the patient was reserved, but able to answer questions and follow most commands during the exam. We also had a conversation about his appointment 5 years ago. While his father chimed in at points, I was speaking directly to the patient, and he was able to explain his perspective. He didn't understand what was happening to him or why. He said there was just too much going on. He was in pain and afraid of being hurt more. During this conversation, what I'm doing is I'm trying to get an assessment on what specific things we can do to better prepare our patient and his caregivers for his treatment plan. I also want to determine which is the best setting for him to receive this treatment. Is it in the hospital or in our normal clinical setting? Next slide. So let's talk about some of the clinical concerns and review them. So we have a history of poor behavior in the dental chair, presumably triggered by a lack of understanding and fear. Due to this distrust in the dental home, the patient has not been receiving regular preventative care. Lastly, there's a long wait for hospital dentistry at this time due to the COVID-19 pandemic, and the patient has an active oral infection. So after reviewing all the risks, benefits, and alternatives to treatment, the patient and his father were able to decide that we should attempt to accommodate the patient's individual needs and treat in a normal clinical setting. So that means we have to use some of the strategies discussed before. Next slide. So let's talk about some of these strategies. The first one is having short appointments. So it's important to develop trust with all of our patients. And with patients with ASD, it's important to be mindful of the hypersensitivities, the inability to sit for long appointments, and any other factors that were noted during the functional behavior assessment that was done in the first visit. So our first strategy, multiple short appointments. We had our initial consult, and we had a completely non-invasive visit. This really helps develop the trust. The next appointment, we're progressively stepping things up, and we're having a dental cleaning, also known as a prophy. The nature of this appointment is minimally invasive, and it's a good exposure into the dental environment and working with us in the chair with model behavior. We also set aside some extra time at this appointment for desensitization, which I will discuss a little bit more in a later slide. So as a quick aside for the business-minded individuals out there, we were able to utilize the behavior guidance insurance code to be compensated for this extra time we're taking for this patient. This code allows for compensation to a dentist who is treating persons with intellectual developmental disabilities due to the increased time, staffing, expertise, and adaptive equipment required to treat such patients with special needs. Now, the average dentist will not be able to use extra time or these strategies if it is not financially, if it's financially untenable. So in California, Medi-Cal public insurance will reimburse for this code. The reimbursement does change state to state, so it's always important to check depending on where you are. But it's also important to note that private insurance companies are now starting to reimburse for desensitization therapies. And we're hoping to see more and more progress on this in years to come. We'll have some resources for this at the end of the presentation. Okay, moving on and back to this story. So the extra time that we use to prepare the patient for, during this extra time we use to prepare the patient for what they can expect and experience during the 2 short root canal appointments. Doing the root canal in 2 appointments allows us not only to keep the appointments short, but also for better healing and decreased chances of a recurring flare-up of infection. Next slide. Okay, so let's talk about the physical environment that we prepare for our patient. So we're using a sensory adapted environment. The idea here is to be aware of the hypersensitivities that affect our patient and modify the environment whenever possible. We used a quiet room, which is a separate operatory with a closable door. And this helps decrease any extra ambient noise from the dental office and any distractions. We also played some calming ambient music and dimmed the room lighting to accommodate the photosensitivity. Of course, in dentistry, we need to use bright lights, so we also gave the patient sunglasses for the procedures. Next slide. Now, before actually doing the cleaning, we also spent some time desensitizing the patient to the instruments and the environment. We utilized tell, show, do, or tell, show, feel, do. So first I introduce the instrument, and then I let dad have a turn, and then the patient has a turn. Finally, I get to have my turn and actually use the instrument to inspect the mouth. We also introduced the sound of the high-speed handpiece, which you can see pictured here. And the patient was able to hear the sounds and observe the water spray, of course, without a burr attached. Now, we even made it so far as to use these model teeth pictured here to place a dental dam with our patient, which you'll see in a photo later on. In pursuit of continuous improvement, my patients would also benefit from a structured visual guide or social story regarding the specific procedure that they're going to experience so that they can take it home and review it with their caregiver. Now, when performing the cleaning, I also used voice control, which is sometimes called verbal anesthesia, to help with pain and anxiety control. And this is essentially being mindful of the tone of voice being used, making sure it's calm and yet firm. We also found that my patient benefited from wearing a lead apron for deep pressure stimulation. And this is great because a lead apron can be found in every dental office. Now, the patient was comfortable with the cleaning. He followed all instructions and had good success. This gave him and his father a lot of confidence in the following root canal appointments. Next slide. So here we return for another short appointment. Profound anesthesia was achieved with no medical mobilization needed. And the patient was even calm enough for me to take this photo. We utilized positive reinforcement throughout the procedure, and he was very compliant and a great helper. We were able to place medicine in the tooth And the patient was able to return in 2 weeks to observe the healing and finish the root canal. Next slide. So the fistula had resolved, that is to say the infection had cleared, and the tooth was completely asymptomatic. So we're able to finish the root canal at the second short appointment. The patient was showing signs of being more confident in the second appointment. After reviewing the plan, and we were able to finish, more of his personality was shining through, and we can see that he was getting more and more comfortable in this dental home. Next slide. So let's review some of the strategies I used in this case. Just because they were successful here, remember, it doesn't mean they'll be successful with every case. And this is why it's important to get to know your patient in that first consult, get an accurate dental history, ask the caregivers what works for them and what doesn't work for the patient, and be able to prepare them with strategies that they can use to help get the patient ready for success. So we used progressive desensitization, short appointments, a sensory adapted environment, use of tone control, positive reinforcement, and that deep pressure. Next slide. Ultimately, this patient had a great win with this treatment and will be returning for comprehensive care with Dr. McGuire in this same dental home. By treating this patient in a regular clinical setting, we were able to establish a strong and safe dental home by increasing his confidence. No hospital setting or sedation was required here, just a little knowledge of autism spectrum disorder populations and knowledge of this specific patient. And of course, a little extra time it took to get there. And if I can do it in my residency with no extra equipment, then really any dentist can. And after all, that is what this is all about. So thank you so much for your time with us. And we're very happy to answer any questions that you might have.
All righty, thank you so much for that awesome presentation on autism spectrum disorder. Just a reminder that you can put your questions in the Q&A box and we'll answer them at the end of the presentation. And we'll also have these slides available for people to look at the resources as well. So now we will move on to our presentation on Down syndrome.
Hi, everyone. So thank you guys all for joining us this evening. My name is Cindy Lee, and I'm a fourth-year dental student at Penn Dental Medicine in Philadelphia. I'll be presenting with Kat Bradley, who's another fourth-year student at Missouri School of Dentistry, Dr. Pariza, a resident of the University of Pacific Dental School, and our amazing faculty mentor, Dr. Perman. All right. I'd like to start off this presentation by first defining what is the Down syndrome. According to CDC, Down syndrome is a condition in which a person has an extra chromosome. Down syndrome is also referred to as trisomy 21 or trisomy 21, and it's the most common cause of intellectual disability and the most common chromosomal condition diagnosed in the United States. The prevalence is about 1 in 700 babies, which means about 6,000 babies born in the United States have Down syndrome each year. It is linked to intellectual disability, characteristic facial features, hand anomalies, and congenital heart defects. For our presentation, we'll be talking about some oral anomalies, oral health considerations, dental treatment plan prevention, and some clinical features with Down syndrome. Some of the cranial facial features you may see are presented here. And commonly we see mandibular prognathism, which is a protrusion of the mandible, as you can see on the right side. There's an extension of the lower jaw, which is also referred to an extended chin, and causes the teeth to misalign. So the small maxilla and the midface create an Engel's class 3 occlusal relationship, which means that the lower molars are forward and do not fit their corresponding upper molars. We also see a highly arched narrow plate and macroglossia, which is a large and thickened tongue that tends to stick out of the mouth. We also see lip protrusion and drooling caused by open bite posture that is caused by hypotonia, which is weak muscle tone. And lastly, we may also see cracks and angular colitis, which is a condition that causes red swollen patches in the corners of the mouth where lips meet and make an angle. Some common dental anomalies and features of Down syndrome are listed here. They include microdontia, which means having small teeth, hypodontia, which means congenitally missing teeth, and some of the commonly missing teeth are lateral incisors, mandibular second premolars, and third molars. We also see greater incidence of impacted teeth and delayed eruption of primary and permanent dentition. And we also may see periodontism, which is a dental anomaly defined by elongated tooth body and pulp chambers, which can lead to increased restorative needs later on. Lastly, we may see enamel hypoplasia. So enamel is the hard protective outer layer of the teeth, and enamel hypoplasia is a defect that causes a lesser quantity of enamel than normal. These can be caused by infections and fevers. And as you can see on the picture here, we have normal to mild, where there can be small grooves, pits, and fissures on the enamel surface. On the moderate enamel, there's a row of deep pits that appear horizontally across the surface. In the severe picture, there's a considerable portion of enamel absent with some yellow and brown stainings.
Thank you, Cindy. So over the next several slides, we're going to discuss multiple oral health considerations that are common among patients who have Down syndrome. Periodontitis is commonly found in patients who have Down syndrome, and periodontitis is the defining term of gum disease that particularly leads to the loss of surrounding tissues of the teeth, bone. Periodontitis is the most common oral health problem seen in individuals with Down syndrome. There are multiple possible causes of the prevalence of this disease in this specific population, ranging from decreased immune system function to decreased oral hygiene care, unique tooth morphology and spacing, and differences in saliva, ranging from differences in salivary flow rate and electrolyte levels in the saliva. Periodontitis is a major cause of concern because this disease process leads to tooth mobility, which in turn can unfortunately lead to tooth loss. If you look on the bottom left of the screen, you can see an intraoral photo of a patient who is suffering from periodontitis. Notice the red inflamed gingiva, the recession in the gum tissue around the teeth, and the bleeding and the plaque buildup. On the bottom right of the screen, you can see a panoramic radiograph showing the bone levels in a patient with advanced severe periodontitis. And you can see the horizontal and vertical bone loss is very evident. The roots of the teeth appear as if they're practically floating in tissue. Next. So another oral health consideration in dental patients with Down syndrome to be aware of is caries. Caries is the formal word for cavities, and they're simply lesions of tooth decay that cause a breakdown of the various layers of teeth, beginning with enamel, the outermost layer, and progressing towards the inner layers through dentin. Decay forms when excess bacteria adheres to the teeth, and these bacteria excrete acid, causing the breakdown and the invasion of tooth structure. On the bottom left of the screen, you can see actually the progression of decay, starting with the first picture and going towards the fifth. The demineralization of enamel is seen in the first picture on the very left, and then progressing to the invasion of the inner layers of teeth, such as dentin, all the way on the fifth picture on the right. On the bottom right of the screen, this picture shows a very characteristic presentation of what dental decay, dental cavities looks like in the mouth. Though caries seems to be prevalent in all populations of people, when examining the population of patients with Down syndrome, specifically children with Down syndrome, these patients have fewer cavities than healthy children. And this is interestingly enough due to one primary factor, which is the delayed eruption of teeth. A delayed tooth eruption is seen widely among children with Down syndrome. Next. So another important health consideration among individuals with Down syndrome is their likelihood to contract certain infections that actually manifest in the oral cavity. One of these on the far left, you can see is Candida albicans infections, commonly referred to as oral thrush, and it's simply an accumulation of fungus, the fungus being C. albicans. It presents as a white coating on the tongue, as you can see, with a red and very sore tissue underneath. Candida albicans is commonly treated with a range of antifungal meds for 7 to 14 days for about 1 to 2 weeks. Another lesion that's commonly found in patients with Down syndrome are Aptus ulcers, shown in the middle picture. These lesions typically are round in shape with a white, yellow, or gray center and a red flat surrounding border that forms in soft tissues of the mouth, ranging from inside the lips, on the inside of cheeks, and or the underside of the tongue. And unfortunately, there's no treatment for Aptus ulcers because Aptus ulcers typically will disappear sooner rather than later, but treatments can manage the symptoms, such as guidance on avoiding certain hard and irritative foods and prescribing rinses such as antimicrobial mouthwashes. And the last infection we're going to talk about is ANOG, called Acute Necrotizing Ulcerative Gingivitis. This is an infection in the gums that's very serious and it's very, very painful. And it's caused by poor oral hygiene, commonly poor nutrition, stress, and weakened immune systems. Fortunately, ANOG can be treated, but if it's not treated early or at all, it can actually become chronic and or recurrent, leading to even more severe problems. And so to treat ANOG, periodontal debridement is typically recommended, deep cleanings, along with prescriptions for mouth rinses and antibiotics are usually recommended. Okay, Cindy, next. So when treating dental patients with Down syndrome, special treatment plans with an emphasis on prevention should be followed. Prevention is key when caring for the oral health of patients with special needs. Dental professionals, whether it be the dentist, dental hygienist, dental assistants, the dental team should recommend visits with the dentist every 6 months, but some may need to go more often due to certain factors. With these visits, certain components can be assessed, and in some cases, a particular intervention called periodontal disease risk early intervention can be completed. And this preventive intervention includes doing scaling and root planing, which is deep cleanings, and sometimes the administration of prescription strength mouthwashes such as chlorhexidine. Another preventive strategy includes orthodontic intervention, and this is needed in cases of severe malocclusion and compromised skeletal development, which is very common in patients with Down syndrome. There are various restorative considerations to take into account as well. Certain teeth with severe cavities may require crowns rather than a simple filling because this provides for a more definitive and long-term prognosis. In weighing certain restorative options, interestingly, implants should be looked into as there are high success rates, as the literature shows, in implant prosthesis in patients with Down syndrome. Now, with the caveat that a focus on oral hygiene must be implemented by the patient. In some cases, when concerning implants, various systemic conditions and developmental abnormalities may interfere with placement. So certainly, as with all things, a comprehensive examination is paramount. Now, removable dentures and removable partial dentures, which is typically recommended in lots of populations of individuals, these are not currently recommended in patients with Down syndrome due to various behavioral considerations and indications. Now, if restorative needs are indicated, behavioral guidance is recommended and is paramount. And the first type of behavioral guided intervention implemented in patients with Down syndrome is desensitization. And desensitization is used to gradually expose the Down syndrome dental patient to the new dental experience by having, whether it's a first appointment that has no dental work done, or maybe having a couple shorter appointments with less complex dental work done first. This exposes the patient in a gradual and comfortable way. Another way to desensitize patients with Down syndrome in the dental setting is to utilize touch, show, do, which we're all very familiar with. Now, if Desensitization does not work, though it is the first line of treatment. The preferred method of behavioral guidance, other things such as weighted blankets are used, and this amplifies patients' comfort and security. In some instances, not as common, but in some instances, papoose boards are still used to contain the patient so that the patient can be treated in a safe, stable, and efficient manner. Sedation is often used as advanced cases where dental work is conducted while the patient is relaxed and asleep, and of course, oblivious to any treatment, not having the memory of the experience. And though we discussed the important preventive strategies specifically aimed at promoting good oral health in patients with Down syndrome, health promotion is critical. A special emphasis should be placed on educating caregivers on how to care for their children or patients' dental needs. This includes encouraging twice-a-day brushing. Also, purchasing different handle toothbrushes are advantageous, and allowing Down syndrome patients who have poor motor skills and dexterity issues to more easily hold and effectively use their toothbrush to brush their teeth. And since healthy diets, as we all know, are a leading cause of healthy mouths, and poor diets are a leading cause of unhealthy mouths, leading to the disease progression of caries and gum disease, a special emphasis should be placed on incorporating healthy foods, emphasizing, of course, that frequency of carbohydrates and frequency of sugar is much worse than the total just raw amount. Next. So over the next few slides, Cindy will be presenting most of this portion of the presentation, but we will be looking at various conditions and diseases that are prevalent among individuals with Down syndrome. And the first we're going to look at here is Alzheimer's. Alzheimer's disease is commonly found in individuals with Down syndrome. Now, statistically, looking at the numbers, approximately a third, about 30% of individuals with Down syndrome who are in their 50s have Alzheimer's, and moreover, half, 50% of individuals with Down syndrome or who are in their 60s have Alzheimer's. So you can see the prevalence and the link between the two. Now, chromosome 21 is the location of this gene, the amyloid precursor protein gene, which produces amyloid protein. And this protein cleaves into peptides, which group together in the brain to form these plaques that are toxic to neurons. Next.
And often individuals with Down syndrome also may present with obstructive sleep apnea. On average, 50 to 100% of children with Down syndrome have obstructive sleep apnea, and nearly 100% of adults have it too. This increased prevalence is likely related to common anatomic abnormalities and a greater risk of obesity and hypotonia. Because signs and symptoms do not often correlate with the disease, all children and adults with Down syndrome should receive routine screening for obstructive sleep apnea. We have some of the anatomical factors listed here, including central apnea, in which the breathing repeatedly stops and starts during sleep. We also have hypotonia and poor coordination of airway movements, as well as narrowed nasopharyngeal passages. And like we mentioned before, mid-phase hypoplasia and macroglossia are listed here as well. And dental professionals are also in unique positions to screen sleep disorder breathing. So it is important to recognize the maxillofacial and pharyngeal features of the disease and inquire about the patient's history of snoring and daytime drowsiness. Individuals may also often present with GERD, which stands for gastroesophageal reflux disease, when stomach acid flows back into the tube connecting your mouth and your stomach. This acid reflux can irritate the lining of your esophagus, and as many as 77% of Down syndrome newborns have or will develop GERD problems. Some of the GERD therapies consist of combinations of conservative, medical, and surgical treatments to heal the injured mucosa and prevent complications. And now that brings us to our poll question to make sure everyone is still awake. And the question is, what is your comfort level with managing and treating a patient with Down syndrome? A, not comfortable at all. B, some level of comfort but have never seen a patient with Down syndrome. C, some level of comfort and have seen patients with Down syndrome. And D, very comfortable and have seen patients with Down syndrome. And there's no right or wrong answer to this question. Okay, thank you guys for participating on this poll. And now I'm going to hand off the presentation to our Dr. Parisa, and thank you guys so much for your time again.
Thank you, Sydney. So now let's talk about the Down syndrome case. So I want to kick this off by giving full credit and thanking our very own Dr. Alan Wong for this rehabilitative following case. So this is the case of a 28-year-old male with Down syndrome. He was initially referred by his dentist, living from about 150 miles away. And this distance reinforces the fact that these patients need dental care, just like anyone else. And sometimes, as you know, it's very hard to access it or to find healthcare professionals who are willing to take on the case or who feel comfortable with the idea. Now, essentially, his chief complaint was with the generalized worn down teeth, as you can see in the picture here, which led to a lot of sensitivity and the aesthetics. We can also appreciate on the upper right picture, the angular colitis that is present on the corners of the mouth, as Sydney mentioned. So let's dive into deeper onto the next slide. So from this picture, we can appreciate the partial cleft palate at the midline and how the teeth are severely worn down on the top surface of it to the point where the dentin is exposed. For those who are not familiar with it, the dentin is the second inner layer of the tooth, so a step closer to the nerve. And that's why the patient is experiencing a decent amount of sensitivity. We can also appreciate that the cusps of the teeth are fractured, canines are worn down. And what's also important to note is that the patient is also taking various medications, including anticholinergic medications. And this is important because of the fact that it can induce xerostomia or a reduced salivary flow, which we will be diving into later on. And for that reason, the patient is also experiencing some decay. So moving on to the next slide, I'm going to start this off with a discussion on what are your thoughts on some of the social and functional implications of extracting all teeth. So the dentist that previously referred the patient had in the intentions of extracting all the patient's teeth. Now, what's important to note is that the most straightforward option is not always the best option. Why can it be problematic to extract all teeth? Well, if we extract all the teeth, then it can potentially lead to a choking hazard, malnourishment, or even a compromised GI tract. You know, you're not being able to chew the food properly. Okay, Sydney, we're going to click again. So I'm also going to ask you guys another question on what are some of your thoughts on applications on CAMBRA, Caries Management by Risk Assessment. So for those of you who are not familiar with CAMBRA, it is essentially a preventative form where patients are categorized based on their relative risk for developing dental caries. We initially mentioned how the patient is taking anticholinergic medications, which can potentially reduce salivary flow. So why is this important? Well, we know that saliva can act as a buffering agent, controlling the pH. When the mouth is in an acidic environment, there's a higher chance of demineralization and therefore more at high risk of developing caries, placing the patient at an extreme caries risk. Now, the biggest takeaway from the slide is that it reinforces the fact that it's always important to find out the underlying cause and treat the disease itself, rather than the consequences and repercussions of that disease. So this leads down to three options. The first option, either to extract all the patient's teeth, which is what his previous dentist had treatment planned. 2, no treatment at all. Or 3, being the most patient-centered and humanistic approach, to consider increasing the bite and placing multiple crowns. So what are some of the considerations and compromised evaluations? So first, do no harm. It is also important to bear in mind, how does the patient function, and are they able to tolerate change? Is the patient patient? It's also important to find out what are some of their thoughts on frequent visits and maintenance. It's something that takes a couple of appointments. In this case, the patient was slightly verbal and had a short attention span, but did work very well with his mother and father. He was moderately intelligent, but he was also willing to try and attempt to cooperate. What was also important to note was that he was not able to tolerate removable appliances, and therefore we gravitated towards something a little more fixed. So I'm not going to dive into the details and the intricacies of the comprehensive treatment plan, but the biggest takeaway from the slide is to understand that it takes a comprehensive treatment plan, and this reinforces the importance of equality and how everyone should be treated equally. So from this picture, we can see that temporaries were made, 6 implants were splinted and designed. And when we move on to the next slide, we can see how we were able to increase the vertical dimension of the bite. And moving on to the next one, we can see the before and after pictures of the comprehensive and rehabilitative treatment that was performed.
Hi, everybody. Thank you for, I can't even describe how proud I am as a co-founder of the AADMD to see where we are today and to see almost 100 people on these calls and great presentations by the students. So next slide, please. So I'm going to tell about 2 stories with Down syndrome. They're cases, but they're stories. And I'll tell you why I asked the students if I can explain why I asked to present. So Kathy, the mother on this side, I met her in 2017 at the Special Olympic World Winter Games in Graz, Austria. Kathy is a pediatric dentist and runs the special care clinic at the University of Pretoria. And she came as a volunteer, but she was in a course to work with me in developing the program of Special Smiles throughout Africa and South Africa. And we spent 2 days treating patients and working together. And then she pulled me over to a chair on the 3rd day and said to me, Steve, I want to tell you why I'm here today. She said, I have 3 children at home and I delivered my 4th baby, and I had just delivered the baby and I was waiting to have the physician to bring him for me to hold my baby for the first time. And he walks over to me and he shows me my baby's feet first. And then he turns the head over and he said, Kathy, your baby has Down syndrome. He said, chances are it's going to be a huge burden on your family. You'll probably wind up in a divorce. Why don't we'll take the baby from you and we'll put it to sleep. And you go ahead and go home. And if you want another child, have another child. And just go on with your life. You'll be able to spend more time with your 3 normal children, neurotypical children. And let's just forget about this whole thing. And of course, in her stupor, she said, like, what are you even talking about? And she said, no, of course I want my baby. And so she took Thapolo home. And I just wanted to show you. So he was 8. I'm not sure how he was, but he was 8 when I met her. And there he is today, 12 years old, thriving, school, a loving member of the family. And I just want you to know that these things are going on today, that in Iceland, in Norway, there are countries that are eliminating basically Down syndrome, almost 100% abortions on prenatal. And I get calls all the time from women telling me stories that they tested positive for Down syndrome. And instead of a physician, a nurse, a social worker, somebody calling them, the testing site called them a few days later and said, when do you want to schedule your abortion? So this is happening in the world, and parents of children and adults with Down syndrome are so incensed by this, but it's something that I think we have to think about, as well as the importance and realizing the importance of giving the news to a parent that they're going to have a child with a disability. And even one step further, with all the prenatal testing that we're doing, we have to learn how to give that news to the parent prenatally as well. So that's one thing. We have to, how can we instill empathy, compassion, just being a decent human being into the healthcare providers that you guys are going to be the next generation for us. Next slide, please. This is a patient. So I'm retired now, but this was a patient in my practice a few years ago. So Gracie was born with Down syndrome, legally blind, and is G-tube fed. And I had been taking care of her since she was a little girl. And she looks like a real sweetheart, but you need a SWAT team to get her into the dental chair. We've never been able to do anything beyond medical mobilization, protective stabilization. But Gracie, when she was born, she had the tetralogy of Fallot and developed post-op complications and developed a severe bone infection. And as a consequence, one leg was significantly shorter than the other leg, as you can see in the photo. She's the only child of the parents. And Gracie had been getting excellent care at Children's Hospital in Boston. And when she was about 12, the physician and the head of orthopedic surgery said, we have to amputate the leg and make a prosthesis because she'll never be able to walk correctly. And it's the best thing for her in the long run. So the parents refused to, they just debated, they couldn't make the decision to do it. And they said, basically, look, my daughter's got Down syndrome. She's legally blind, G-tube fed. How can we do this? The physician said, I'm one of the world's expert in this. We need to do this. This is the only treatment. They go for a second opinion at Johns Hopkins Hospital, and they meet with the orthopedic surgeon there, and he looks at the records and he says, oh, you're seeing this expert at Boston. He's fabulous. I agree with him. And the parents, without even an examination and stuff, and the parents said, what are you talking about? Will you please examine her and give us advice? And he said, no, I'm not going to contraindicate what your expert says in Boston. So they came back and they were so distraught, and they reached out to me and said, Steve, what are we going to do? Can you help us make the decision? And I said, let me do a little digging myself into this. And I called my colleagues in the AADMD, and we found a surgeon in Florida that specializes in limb lengthening. And the parents went down to see him, and he took one look at at Gracie, and he didn't see a child with all these multiple problems. He looked at a leg and he said, I can fix this. And he did it. And he did the limb lengthening operation. And Gracie is fine today and walking great. And I can't even, every time I see the parents, they basically almost cry because they said that we were this close to amputating my daughter's leg. And the point I want to make is that you have to be, whatever health profession, you have to become an advocate for your patients with disabilities. They are beaten up so badly by the healthcare system. And sometimes it's just a sympathetic, empathetic voice that they can turn to. And so I'm not worried about you guys. in your future practices, because you're all the fact that you're part of this organization means that you have that. But so much of what we do with this population comes from the heart. And I just wanted to talk about those two stories. Okay. Thank you, everybody, I know it's late, but I appreciate the attention. Thank you.
Thank you so much. Just hearing all of our residents and students and all their stories and all their knowledge is encouraging, even from the medical standpoint. It's a lot to learn. So I'm sure all the attendees are just very thankful for all the information. And now I'll pass it on to Dr. Wong. I know the time is running very slim, but if anybody has any burning questions, I see one and I will read it aloud. From an anonymous attendee, it says, do you encounter issues with Medi-Cal not covering treatment options that would normally be considered and viewed as important or desirable advances in care? Any advice? And I can read that again because it's pretty long. Anybody can answer.
Okay, I'll answer.
Yes.
Often doing the right thing means doing the right thing, whether you're paid for or not. It's people like Dr. Perlman, it's people like yourselves that will champion this and be the voice for those without the voice. And I think those cases that were presented before, often people say, well, just extract the teeth. But inclusive healthcare means, what would you do if it were you? So that's what we're trying to do. We're trying to educate the insurance payers. We're trying to educate Medicaid, Medi-Cal, Medicare that to be compassionate, we need to address the patient and not their diagnosis. So that's what I have to say. So yeah, they don't pay for it. Heck, we're going to do it anyway, and we're going to find some funding for it because everyone deserves the right to smile. I think we have time for another question, Ademiola. What do you think?
Yeah, for sure. There's no new question, but if anybody has a burning question, just feel free to pop it in the Q&A box and we have time to answer it. One more. Let's see.
Okay.
I'm not seeing any new questions.
Not having any. I just wanted to thank you, audience, for staying around because all of you seem to stick around for a very long time. This is a very interesting way to present these virtual grand rounds. We learn a lot. I'm very impressed with the students and the residents who put together a fantastic presentation, and I thank the faculty that worked with them. I want a special shout out for Dr. Jeanette LaBelle, who is our actual coach and leader in this whole thing to help coordinate and spearhead this. But this will eventually be part of our national curriculum for inclusive health, and I'm looking forward to rolling this out. As many of you know, curriculum is everything. And to train our future dentists and our future medical doctors and future healthcare providers, it's important that we have curriculum that is meaningful and relevant and clinical so that we can produce better clinicians and have better access to care of providers that are at their top level. So that's what AADMD is going to work on this year. I look forward to seeing you on our next VGR rounds. Thank you, Ademiola, for hosting us and being there for us as our VGR moderator. I appreciate you, and I appreciate everyone here on this panel. So thank you, wonderful job. Hats off to you all. Thank you. With that, I wish everyone a great night and keep up the great work in AADMD, you student leaders and you faculty. Thank you.
Thank you. Good night, everyone.